welcome to the deep dive. Today, we're taking a really close look at something that's, foundational for quality of life for just about everyone listening: hormone optimization, for men and for women.
Exactly.
We've pulled together a ton of expert clinical and scientific sources, and our mission here is to give you actionable tools and the context you need to go way beyond just a basic blood test.
Yeah, we're moving past that baseline panel. The analogy I always come back to is the body as a car. Every single body is different. You might have a marathon engine or maybe a reliable family sedan.
Or a supercharged race car.
Right. And each one needs a very specific, personalized fuel and maintenance schedule. The generic approach, it just doesn't work for optimization.
So let's start there, the very first step. How do you even get your doctor to order the right tests, the ones that give you useful data?
Okay, so the key is you absolutely do not need a full-blown pathology.
A diagnosis.
A diagnosis. What you need is a clear record of your symptoms, showing a change from your baseline. So don't just ask for a hormone test. You go in and say, my energy has dipped, or I'm struggling with focus, or my athletic recovery is just not what it used to be.
So it's about that personal subjective change.
Precisely. That's the indication.
That's a key distinction. But the sources point out this really interesting contrast in how men and women even talk about these things.
Oh, it's a huge psychological hurdle. Women often come in with more, let's say, objective data. They can point to menstrual irregularities, things like that. They're comfortable with that conversation.
It's a trackable cycle.
Exactly. Men, on the other hand, they might want to know their testosterone, but they can be really hesitant to admit to changes in libido or energy.
Because it feels like admitting you're less masculine.
That's the psychological link, yeah. And that hesitation can lead to a less thorough initial workup.
Okay, so let's pivot from diagnostics to lifestyle. Before we get into any kind of medical intervention, the sources lay out these big 6 pillars for hormone health.
And they really hammer home this idea of the law of diminishing returns.
Which is so important.
It is. It just means that small, consistent changes over a long time are so much more effective than these huge, sporadic efforts that you just can't sustain. You're building a foundation.
Not sprinting a single lap.
Exactly.
And within those 6, there are 2 that the sources call the absolute strongest drivers.
Diet and exercise, no surprise there. For diet, it has to be individualized. Going back to the car analogy, the fuel has to match the engine.
So things like genetic testing can help.
They can give you a starting point, yeah. For things like your personal tolerance for carbs or sugar. But, and this is a big but, that data is useless without a physician to interpret it. You can't just read the printout yourself.
And on the exercise side, we're talking specific types of activity, not just, going for a walk.
Right. All movement is good, but resistance training is specifically singled out as being great for hormone health.
And then for cardio.
For cardio, the recommendation is a minimum of 150 to 180 minutes of zone 2 per week.
So that's the low-intensity work where you can still hold a conversation.
That's the one. And what's interesting is the more dialed in you are on that zone 2 cardio, the less you might need extreme caloric restriction later on.
That's a great point. Okay, let's get to the other 4 pillars. We've got diet and exercise, so we have to talk about recovery, starting with stress.
And stress optimization isn't just about, feeling less worried. It's about managing cortisol. And this is a really interesting detail. Optimization is way more effective as a household unit.
You mean doing it with your partner or family?
Yes. The success rate for any big change goes way up if your spouse or close friends are on board. You're a collective.
Which flows right into the next pillar: sleep.
Sleep is not optional. It's essential, particularly for mitochondrial health, the powerhouses of your cells. Then you have sunlight and the outdoors.
Which is more than just getting a tan.
Oh, much more. It's about moving more. It's cold exposure, heat exposure. These are powerful hormone modulators.
And the final one, number 6, might seem a little surprising in a science deep dive: spirit. Body, mind, and soul.
The sources are really clear on this. You can have the other 5 pillars: perfect diet, exercise, sleep. But if your spiritual health is in crisis, however you define that,
it will show up physically.
It will profoundly impact you physiologically. It's a Venn diagram. Optimal health is in that overlap. We tend to compartmentalize these things, but the body doesn't.
Okay, let's zoom in from those big principles to something really specific: caloric timing and fasting.
Right.
If someone starts caloric restriction or intermittent fasting, what's the real goal here?
The goal should always be increasing your health span, the quality years of your life, not just what the scale says. But we need to get into a really critical nuance about caloric restriction, or CR, and testosterone.
Okay, because CR is often sold as this magic bullet for everything.
It's totally context dependent. If a person is obese or has metabolic syndrome, CR will almost certainly improve their testosterone. Their body needs that stressor.
Right.
But, and the literature is very clear on this, if you are young, lean, and healthy, aggressive long-term caloric restriction will likely decrease your testosterone. You're stressing an already optimized system.
So for a fit listener, a big calorie deficit could actually work against their goals. Yeah. The maintenance for the race car is different from the repair plan for the broken truck.
Perfect analogy. Now, what about intermittent fasting, IF, for that healthy person, if they're still getting enough calories overall?
In their eating window.
Right. In that case, IF is not detrimental to hormone health, and this ties right into growth hormone, or GH.
And GH is a peptide hormone, a chain of amino acids, not a steroid hormone like testosterone.
Correct. And you naturally get a big spike of GH overnight. Intermittent fasting improves the quality of that spike.
So how long do you have to fast to get that benefit?
The good news is you don't need a multi-day fast. Just avoiding food for 2 to 3 hours before you go to sleep still gives you a really robust GH output.
So you get most of the benefit from that simple change, with maybe a little extra gain if you go longer.
Exactly. Diminishing returns again. The effort gets steeper for a smaller and smaller benefit.
And when we talk GH, we have to talk about IGF-1. Can you break that down for us?
This is such a crucial distinction. You have systemic IGF-1, which is mostly made in the liver. Then you have local IGF-1, which is released right in the muscle after resistance training.
And which one actually changes your body composition?
It's the local release. That's what seems to improve muscle repair and body comp. The systemic level you see on a blood test, that's mostly the liver-driven one, and it just doesn't tell the whole story.
That is a huge distinction. Okay, let's transition to androgens, specifically testosterone in women, where there are just massive misconceptions.
Huge.
For a woman who's optimizing, is knowing her testosterone level as important as knowing her estrogen?
For overall health, quality of life, motivation, yes, absolutely as important. But we have to separate goals. For preventing pathology like breast cancer or osteoporosis, estrogen and progesterone are still more critical.
But we always hear that women have such a tiny amount of testosterone. Why is that measurement so confusing?
It's a measurement and a binding issue. So first, most of your hormones are bound up by a protein called sex hormone binding globulin, or SHBG.
Taxi service.
The taxi service, exactly. And it binds so tightly that the hormone can't act on tissues.
And it prefers certain hormones over others.
It does. It binds the strongest androgens most tightly. So it binds DHT the strongest, then testosterone, and then estrogens, like estradiol, are the weakest.
So what's the big measurement insight?
It's that if you look at the total amount, almost all women have significantly more total testosterone than estradiol. It's just confusing because they're measured in different units, nanograms versus picograms.
So let's focus on DHT for a second. It's a powerful androgen in men and women. What's its positive role? We always hear about blocking it.
Right, but it's critical for motivation, for drive, for that get up and go feeling. It acts on the androgen receptor. And fun fact, the gene for that is on the X chromosome, so men get it from their mother.
So if it's so important for drive, why is everyone trying to reduce it for things like hair loss?
That's the trade-off. If you block the enzyme that converts testosterone to DHT systemically, you risk losing that drive, you risk sexual dysfunction. It can be a huge hit to quality of life.
Which is why localized solutions are better.
Infinitely better.
Are there any natural ways people try to modulate that enzyme?
There are. Plant polyphenols can inhibit it. The classic example is curcuminoids from turmeric and black pepper. But if you already have low DHT, you might actually want to avoid those.
But for hair loss, if you want to avoid those systemic side effects, what's the best tool the experts cite?
The most promising strategy is topical dutasteride mesotherapy. So localized injections right in the scalp. It only decreases DHT conversion locally.
Okay, let's shift to a very common but underdiagnosed condition. Polycystic ovarian syndrome, or PCOS.
The prevalence is shocking, like 10 to 20%. And most women don't find out until they're in their 30s, often because of infertility issues.
What are the key symptoms to look for?
The main thing to know is you do not need to have polycystic ovaries on an ultrasound. It's a group of symptoms. You're looking for 1, androgen excess, so acne, hair issues. 2, insulin resistance, that's the primary driver. And 3, oligomenorrhea, which means long menstrual intervals.
So it's a metabolic disorder first that just expresses itself hormonally.
That's it. So the tools used to treat it target that insulin resistance. Things like metformin or supplements like inositol.
Myoinositol and D-chiroinositol.
Right. Minoxidil is the insulin sensitizer, and D-chiroinositol is also a weak anti-androgen.
Moving from conditions to substances, marijuana and alcohol. What's the real story with cannabis and testosterone?
It's interesting, the cannabinoids themselves, THC or CBD, don't directly reduce it. The problem is the delivery method. Smoked marijuana is likely to increase aromatase.
The enzyme that converts testosterone to estrogen.
Exactly. So more estrogen signals the pituitary to make less testosterone. It's a similar mechanism to opiates.
And high alcohol intake.
Definitely decreases testosterone. Same goes for other potent GABA agonists like benzodiazepines. They all have that suppressive effect.
Let's tackle a really common sleep issue. Waking up at 3 or 4 a.m. for no reason. Are there hormonal flags for that?
Absolutely. 3 big ones. First, it can be a sign of true growth hormone deficiency. Second, vasomotor symptoms of menopause or andropause.
And the third one is a huge warning for men starting hormone therapy.
It is critical. If a man starts testosterone replacement therapy, TRT, his sleep can become terrible. Why? TRT drastically raises the risk for obstructive sleep apnea. It can also just put you in this hypersympathetic, high alert state.
While we're on TRT, let's address the elephant in the room, prostate cancer.
The science is clear. TRT does not cause prostate cancer. Normal aging does. You have a 50% chance by age 80. But if you have existing prostate cancer, testosterone will grow it. So you are adding fuel to a fire if it's already there. It requires a very serious individual assessment.
Let's talk about the dopamine wave pool concept.
It's a great analogy. You want nice, even waves of dopamine for focus and motivation. You want to avoid the big overflow and then the crash. Prolactin is a huge inhibitor of that.
And prolactin follows estrogen.
It does. High prolactin then dampens dopamine and inhibits testosterone release from the pituitary.
So if someone has high prolactin, what's a tool they can use?
A good place to start is eliminating mu-opioid receptor agonists in the gut. The main culprits are usually casein, which is milk protein or gluten.
Fascinating. Let's shift completely to relationships. The sources talk about hormonal crosstalk between partners.
Even things like menstrual cycle alignment. It tells us that spending 100% of your time in the same hormonal bath can lead to burnout.
So the power of distance.
Yes. Taking a trip apart, even just for a weekend, it resets the dopamine circuit. It creates excitement.
And this becomes a vital strategy during a crisis, like having a newborn.
Absolutely. You have to plan ahead for those life crises. When you have a baby, you have to assume both partners will have high prolactin, low dopamine, and low testosterone from stress and sleep deprivation.
Exhaustion doesn't lead to romance.
Not at all. So strategic planning, scheduling time apart, scheduling good times before the crisis hits, it's essential relational medicine.
Finally, let's talk peptides. They are everywhere right now. Are they safe? Dangerous.
They are very heterogeneous. They can be very safe or very dangerous. I mean, the original peptide is insulin, and that can kill you if the dose is wrong. They should almost always be prescribed by a doctor.
For growth hormone-releasing peptides, or GHRPS, what's the serious risk?
Tumor growth and cancer. If you look at type 1 diabetics, they have high GH, low IGF-1, and very high cancer rates. Since you can get the benefits like fat loss elsewhere, GHRPS are often an unnecessary risk.
What about BPC 157 for injury recovery?
It's a compound that increases something called VEGF, which promotes blood vessel growth and healing. Great for tissues with poor blood flow, like ligaments or tendons.
But there is a massive cancer warning here.
This is critical. If you have cancer or a high risk, you must avoid BPC 157. Essential anti-cancer drugs work by inhibiting VEGF to starve tumors. BPC 157 does the exact opposite. It could accelerate an existing tumor's growth.
And a final warning on sourcing these things.
It's a quality control nightmare. Non-prescription sources often contain LPS, a bacterial fragment that causes a fever and inflammation. People inject it, feel sick, and think the compound is working. It's not.
It's just a contaminated product.
Exactly. You have to work with a physician and a compounding pharmacy that cleans the LPS out.
Quickly, melanotan or PT141. What is it approved for besides tanning?
3 things: hypoactive sexual desire disorder in women, lipodystrophy, and a rare genetic condition. The main risk is if you have a personal or family history of melanoma, because it could potentially accelerate its growth.
Last question. Back to the big 6. Caffeine. How does it affect hormones like testosterone?
It's neutral unless it messes with your sleep. If it fragments your sleep and hurts recovery, then you'll see the downstream hormonal problems. But the compound itself isn't the issue.
We have covered so much essential ground. The need for a personalized approach, the power of those big six pillars, and the importance of using localized, targeted solutions.
And my final thought is that integrated model. You can't separate body, mind, and soul. You need an approach that brings your spiritual, mental, and physical health into alignment. That's the cornerstone for everything else.
That integrated model is the perfect takeaway. And since hormonal shifts like low dopamine after having a child or high cortisol from work inevitably affect our relationships, what proactive planning can you put in place today? Whether it's strategic time apart, an intentional spiritual practice, or targeted supplementation, what can you do now to protect your relational health before a crisis hits? Thank you for diving deep with us.